everyone, and welcome to another Heart for PCOS interview. I am thrilled to be able to sit down and chat with our very special guest today, Dr. Kathryn Rexrode. Dr. Kathryn Rexrode is the Chief of the Division of Women's Health in the Department of Medicine at the Brigham and Women's Hospital and a professor of medicine at Harvard Medical School. Additionally, she is the director for the Office for Women's Careers in the Center for Diversity and Inclusion at Brigham and Women's Hospital. Thank you so much for joining us today to talk about PCOS, women's health, and cardiovascular disease.
Oh, thank you so much. I'm so excited to be here.
So I wanted to start off with asking a really big question, and it's kind of a loaded question, so forgive me. But through research that has been done to date, can we determine yet that PCOS can lead to cardiovascular disease, or at the very least, increase risk factors for cardiovascular disease?
So it seems like this question would be very easy to answer, and it has proven more tricky than you would think. And we can get into a little bit of the why. In terms of the second part, I think we can definitely say that PCOS is associated with increased risk for cardiovascular risk factors. And so we know increased risk for diabetes and glucose regulation problems, for lipid abnormalities, so cholesterol abnormalities, some increased risk for hypertension, higher risk of obesity and central fat sort of collection. So that is without a question, like very well connected. And each of those risk factors has definitely been related to cardiovascular disease. So I think the way I could say it, or the way that I would talk about it with my patients, is that individuals with PCOS are at heightened risk, though it may work through the standard cardiovascular risk factors. And that's a bit of it sounds like a bit of a semantic difference. It's hard to separate, is it something separate, or what that pathway is. But I think it's really important, and that's why I'm so glad to be here today, for individuals with PCOS to realize that they are at heightened risk, and there are things that they can do to reduce that risk. So recognizing that risk and reducing that risk is something that should really be a priority.
And you just gave me a beautiful segue to my next question, which is, I would love for you to give us a sense of how important it is that we start to recognize PCOS as more than a reproductive issue, but a cardiometabolic syndrome that could profoundly impact future health.
Absolutely. I think, PCOS very commonly comes up with menstrual irregularities, right? One of the sort of hallmark features, the thing that brings people to attention first, often through a gynecologist's office, and a very important issue related to, menstrual cycle and other issues. And so it kind of gets lumped into that reproductive space. And I don't want to diminish, there are important factors to consider there. So I don't mean to minimize them in any way, but I think that often leads to thinking about it as a reproductive issue rather than a whole body systemic issue. And I think in the past several years, we've really focused attention on what we consider female-specific risk factors for cardiovascular disease. We've increasingly recognized certain pregnancy complications in that category, early age at menopause, and PCOS is not yet on that list officially. There's a few more details to do to sort of nail it down to that level of evidence, but I absolutely think we need to recognize it as having systemic implications, and that cardiometabolic piece is really important to recognize, understand, and then actively manage to prevent those increased risks.
Yeah, so talking about this systemically, one thing maybe you can connect for people, because it is connected to reproduction, is that the reproductive system, some of the organs are actually part of the endocrine system as well, correct?
This is true. This is true. So yes, obviously the name polycystic ovarian syndrome, and that name, as you know, has also been debated as to what the best name to represent this would be. So you have different guests, I'm sure, that will address those issues. But, that polycystic ovary and ovary having, extra follicles and these cystic follicles is in the center. And obviously our ovaries are the main producers of estrogen, of, sort of regulation in menstrual cycle. And estrogens have a lot of impact throughout our bodies. And it's also, clear that polycystic ovary syndrome also interacts with androgens. So women and men both have, androgens, testosterone, DHEA and DHEAS. And, those are also part of the dysregulation in polycystic ovary syndrome. Now, I am not an endocrinologist and I can't draw you the diagram of exactly how the ovaries and, each of these things and the feedback loops with the pituitary and hypothalamic pathways work, but we know that those are cardinal features and they probably do relate to part of that risk. One of the earliest things I studied in my own work was sort of abdominal adiposity and risk of coronary heart disease, that sort of apple shape versus pear shape. And the deposition of fat sort of in the middle, what was often called a male pattern or apple pattern, was associated with higher risk for cardiovascular disease, heart disease, as well as stroke. And that pattern is associated with higher androgens. And many of the individuals, in your resource group may also recognize that, like this stubborn, like I can lose the weight, but I'm just not losing it from where I want to be losing it. That's hormonally sort of regulated, both through androgens and sort of other pathways. So, I think you're absolutely right to call it a cardiometabolic syndrome. And I know some people have thought about changing the name that would balance it a little bit more in that direction, because I think that is part of the problem. If we have ovary in the title, people kind of like zoom in to it being reproductive rather than it being systemic. So I think absolutely hormones are involved. They're not the only piece of the puzzle, but they are a big piece of the puzzle.
Absolutely. So what are the implications if we continue to dismiss this condition or downplay it, how it affects cardiometabolic health or increases risk factors like higher lipids or lipid abnormalities, high blood pressure, insulin resistance, and ultimately cardiovascular disease?
Well, I think as you're saying, if we don't manage the risk factors and we don't recognize PCOS as being at risk, then those risk factors build up over time and can lead to earlier heart disease, earlier stroke, higher risk. And obviously that's something we want to avoid. I'm a primary care doctor in my clinical life, so I'm all about prevention, right? This is about, and also understanding our health and how to take responsibility or take control of our health and understanding what should I be keeping an eye on. So all of those factors we described are ones that it's really important for an individual to talk with their primary care provider or endocrinologist or whoever's their main point person. But in knowing your numbers, right? Knowing how does your insulin resistance or glucose sort of regulation look? How about your blood cholesterol? How about your blood pressure? Those are numbers that it's important for everyone to know, but really important for individuals with PCOS to know.
Right. So I wanted to go back to one of the things that you had talked about previously, which is the abdominal adiposity, or carrying the excess waste around the midriff. Because I know in your research that you have found this could be another risk factor for PCOS patients that could lead to coronary heart disease or cardiovascular complications. So one of my questions is it independent of weight? I mean, could somebody be thin and still have cardiovascular risk because they carry that weight around their midriff? I mean, because I think a lot of people get caught up with that only happens with women that are bigger size with PCOS, but I'm wondering if it affects anyone, any size.
Yes. So, there was a time where people would talk about lean PCOS and not, or lean being a variant, because I think people associated excess weight with PCOS, and that can happen. But absolutely, there are individuals who have a normal body weight, however we define that, and that in itself is fraught. But who still perhaps have more of their weight distributed in the trunk. probably have higher androgens as part of, again, that systemic condition. And when we worked in my studies to sort of separate it from weight, which we commonly use something like body mass index, BMI, to measure, it does seem separate. So yes, you can have a lean or normal body weight, BMI, whatever we want to call it. Each one of them have their issues, but also have more weight in your waist, not carry it on your hips and thighs, and be at somewhat higher risk than somebody with the same weight who, let's say, did have more of that classic pear shape. So we use something called the waist hip ratio, which is sort of, you can imagine sort of the apple, or we could just call it a rectangle, right? That's sort of straight up and down, waist and hips about the same. Or you can have somebody who has, the smaller waist and wider hips. And in general, at the same weight, that second pattern, that pear pattern, usually looks to be at lower cardiovascular risk. Now, we can't turn ourselves from pears to apples so much. We can do lots of things to modify our risk, though, and I think it's just important to recognize that there is this spectrum, and that that some of that is really hormonally influenced, but there are ways to help reduce risk. It doesn't mean that just because you have that more rectangular shape, that you are doomed to have cardiovascular disease. There are things that individuals can do.
And that's why I love this, because according to the American Heart Association, 80% of cardiovascular disease is preventable. And that starts with doing things like this, which is education and raising awareness. So thank you for that.
Oh, no, thank you for getting us out here talking about this.
Absolutely. So often when we talk about cardiovascular disease, we talk about the heart. However, patients with PCOS also have a 4 times higher risk for stroke. You have presented the need for more research on stroke risk factors in women. And is including PCOS as a risk in this research important? And if so, why?
So absolutely, it's important. I think one of the limitations, not to make excuses for all of medical science, but often big studies have been somewhat blind to asking about what are considered female-specific risk factors or reproductive risk factors, right? So that's true for a lot of the studies that didn't ask about pregnancy complications, and especially true for asking about PCOS. And so often we don't have the data we wish we had, to really be able to nail down the answer to this question. And I know we've had recent workshops at the NIH to really convene people and resources to make that research happen. So I am optimistic towards the future. But yes, I think it is critically important that we understand that equation and understand how and the degree to which PCOS is associated with stroke. Many of the stroke risk factors are exactly the same as those for heart disease. The higher blood pressure and lipid abnormalities and diabetes or glucose intolerance, insulin resistance. So, the message is similar, but, stroke is a really devastating condition, and one where women do suffer, more from strokes than men. More women die of stroke each year. So absolutely, preventing strokes is critically important, and understanding that relationship for stroke and really having PCOS on the list of conditions as we nail down this data, I think is really important.
Awesome. So literature often terms PCOS as a condition of reproductive aged women. However, we know PCOS can affect girls as young as 8 and does not disappear after menopause. Why is it important that we review PCOS across the lifespan, which is something that we did in the NIH workshop? And how can that potentially reduce health complications and risk factors for things like diabetes and cardiovascular disease?
Well, I think the way you've laid it out is exactly true. This is a condition that affects individuals across the lifespan. So starting in adolescence, through young and middle adulthood, and into midlife. And after the ovary part of the equation is sort of, not dropped out completely, but, is no longer the driving factor. For cardiovascular disease, risk is really cumulative. So we know that, it's decades of exposure to lipids that are really making, the issue. So it's never too early to start on reducing that risk. And as I talk with an individual, let's say, who's in their 50s, and I'm trying to assess their cardiovascular risk, often we end up with somebody who we might say is sort of on the edge, right? Not into a clearly high risk category, but somebody who's in this low to intermediate risk that's a little hard to determine. And maybe we're making a decision about, do we treat blood pressure or do we treat cholesterol? And in that setting, understanding somebody's exposure over their entire life course up to that point is critically important, because that should change how we think about treatment at that time, or at least, a discussion about it. It's not that it's always the right treatment and a decision to treat with a medication, but to think about how to lower that risk and how to assess that risk. It isn't a disease that completely vanishes after menopause. Many of the peskiest symptoms might reduce after menopause, and some of the women without PCOS start catching up with some of the things that PCOS women might have struggled with already, a higher androgen to estrogen ratio that's causing them to have stubbornly, rectangular apple, sort of holding on to fat, or maybe problems with, more noticeable hair growth. I mean, again, not to say it's the same, but menopause does echo some of that androgen estrogen balance shifting, which is so important for both individuals with PCOS and the general population. So absolutely doesn't stop just because your periods have stopped, but thinking about that exposure over the life course, and even as teenagers are being diagnosed with PCOS, thinking about how to keep healthy over the long term, that's really the goal.
Yes, because I've actually seen research that indicates that girls in their teens and in their early 20s can actually start developing plaque deposits that can lead to like atherosclerosis as a risk factor with PCOS. Could you talk just a little bit about that?
Sure. So the process of developing atherosclerosis, or those plaques, and I think we've all seen different kinds of pictures at one point or another of these sort of hard, yellowy kind of deposits that are in the blood vessels, particularly in the heart or in the neck, and our carotid veins there, that are carotid arteries that take blood to the brain. Those plaques do develop over a long period of time. So it starts with fatty deposition, which sometimes are called fatty streaks. And those can start very early, and they start early when there's too much cholesterol in the blood, or, the wrong kinds of cholesterol, high LDL cholesterol, low density lipoprotein. And again, that's what I was sort of saying, over the life course, it's cumulative.
Yeah.
And so that means that an individual who has higher lipid levels as a teenager is just exposing their blood vessels to more cholesterol over the lifetime. And it really is kind of cumulative exposure. For instance, we know that individuals who have different kinds of genetic conditions that lead to high cholesterol levels, the sort of the slope or the time course to developing those plaques is different. And so PCOS is on that spectrum. So yes, never too early to start on the prevention front, thinking about those lifestyle behaviors that reduce cholesterol and improve, reduce the risk of developing plaque. One thing I had not mentioned, which is not part of PCOS, but just to drive home, is controlling your other risk factors. So for instance, smoking is a multiplier for every single risk factor, right? So, thinking about the healthy lifestyle things, not smoking, engaging in physical activity, a healthy diet, eating the rainbow of fruits and vegetables in a Mediterranean diet kind of way. These are things that, again, also over the entire lifetime can have a really beneficial effect. We were sort of talking about how PCOS might exert that higher risk over the lifetime, but the earlier we start in the lifetime on the prevention strategies, the better as well.
So this is a really important question to me. And as someone who does a lot of research, I'm sure this will be important to you as well. As it stands right now, the NIH dedicates less than 0.1% of funding towards researching PCOS. So why do you feel it is important we keep investing in and funding research of PCOS and cardiometabolic health?
Well, I definitely want that number to be higher. And, I think, as you probably know, I think, as you probably know, the numbers for sort of women's health related conditions or conditions that affect predominantly women are lower than they should be, and something we have to continue to be fierce advocates for. And I know you are indeed. The reason it matters is because really, in order to shift sort of clinical practice, physicians really need a pretty high level of evidence.
Yeah.
And so, especially to create a guideline that says individuals with PCOS should have X or Y or Z treatment, and we have the evidence to show that that is important and safe and, improves outcomes. We don't have that yet.
Yeah.
We have hypotheses that are strong hypotheses and a lot of supporting evidence, but we don't have that sort of what we consider A-level evidence, right? And that is really what it usually takes to really shift clinical medicine. So absolutely increasing that minuscule amount to something that, will get us some real answers is absolutely part of the answer.
Absolutely. So do you think research is finally heading in the right direction for PCOS patients as far as finding its cause and ultimately a cure?
I don't know what those answers are yet. I do feel like there has actually been a really positive groundswell, and I should really call out your organization and other patient advocacy groups for being part of that, raising up voices, and patient voices are really important in this so that it isn't a silent disease, not that it was silent to the individuals having it or to the physicians treating them. But so I think there has been a real groundswell. I also feel like we're in a moment of recognizing again, what we call female specific risk factors. And I want to acknowledge that some individuals that have polycystic ovary syndrome might be non-binary or could be transgender men. And so I don't want to exclude them by that term. So please, I want people to understand that. But conditions that have not traditionally occurred in, XY individuals, or, at least at their genetic makeup at birth, have tended to be understudied. And that's why I think we're in the midst of recognizing a number of risk factors pointing to the pregnancy related factors, the hormonally related factors, the early menopause, and PCOS, as really digging into them and saying, we can't leave that out from the equation. We've had, a sort of a male-centric version of cardiovascular disease. I think for so many years, decades, people thought of it as a man's disease. It was, through that lens. And so really asking what's different among individuals who have pregnancies, who have ovaries, who have this risk is really, really important. I think there is a lot of research going on some of the genetics around PCOS, and that really may unlock some of those real treatments and cure answers. That's not my particular area, so you'll have to have somebody else wax poetic about that. But I do think it's a very exciting time, and I think it's the right time to get those answers. And again, I want to thank you and your organization and others like it for the advocacy, which does matter. And as a medical research, pledge back that, yes, we have to fight too. It's not just on you, it's on our shoulders as well for advocating both to conduct the research and to get it funded.
And thank you for saying that, because that's why I've been doing this for the past 10 years, because I believe that when it comes to medical conditions like PCOS, it really has to be a partnership between patients, providers, and researchers. So I really appreciate you taking the time to talk about research, to talk about how we can improve care, and sharing your expertise in all of these areas. I would love you to let everyone know if there's a way that they can learn more about your research through social media, your practice, your website, or your published works.
So we can definitely make certain you can attach the link to our Division of Women's Health, where my research is featured and others, and put in some other important links like to the PCOS workshop. And I'd really, I feel very privileged to be in this partnership, and I absolutely think of it as a partnership. When I'm working one-on-one with a patient, it's, us as a team, and thinking about how to really improve health. And as a researcher, it's not one-on-one, it's we as a research community and you as a patient community, and really, again, working together to really see those advances that we need. So it's really been a pleasure talking with you.
Thank you so much. And everyone, this is a true testament as to why research is so vital and why we have to continue fighting for research and researchers like Dr. Rexrode to do the important work that they're doing. I thank you for joining us this afternoon and encourage you to check out all of our other interviews, events, and live streams throughout the month of February for Heart for PCOS. Thank you and have a great day.